We have large urban areas. That's one reason. Where obviously virus can concentrate and where people use a lot of communal spaces, and this is a virus that's easily transmitted when people are up close and personal. We have a population that's used to independence and freedom and not being sheltering in place. It's not our habit to do this. We're a very independent people, and we don't currently have a central organization for doing the social distancing in an organized fashion throughout the country. And this is such a rapidly moving virus that with those combinations of factors and the fact that we were delayed in starting our whole testing process, there's a serious risk that we're going to have a very fast climb, as we're actually seeing. We all know that children have a lower risk of having severe or critical disease. And that was broadcasted fairly well. But what wasn't broadcasted well enough is the fact that you're just as likely to get infected whether you're 3 years old or 60 years old. It's a matter of how the disease manifests in a person. And that 3-year-old that isn't showing very many symptoms or none at all is still contagious to everybody else. Moreover, and we're now seeing this, when we see all these numbers climbing, and you remember that we still have a 2.4 to 3% chance of a severe illness in a child, that means we're going to see more and more children who are going to be severely ill. And as we've already seen, some children have died. Well, the Defense Production Act allows for the president to basically demand that companies produce the things that are needed or lend the government the things that they have that are needed in order to more quickly end this problem. And we have a lot of problems with supply chain at all levels. We have problems, as you know, with masks and other PPE. We have problems with reagents for doing the testing. We have problems with medications that, especially now that we're uncovering some medications that have some promise, we need to be able to enact that law so that a series of pharmacies can produce the needed medications, and so that we don't run in short supply, because we don't have to. We can do that. We have that capability. Moreover, just today, I was on the phone with a hospital administrator because they are concerned in many hospitals that very, very soon we will not have the ICU beds and the ventilators and all those other things that we desperately need to take care of the numbers of people that are going to need that level of care. Because remember, it is a numbers game, right? So that 20%, as those numbers go up, that's a number that goes up too. And we have a limited amount of ICU beds. In fact, hospital administrator I was speaking with was talking about maybe employing garage space. But that's not ideal. And we have a better option if we apply this Defense Production Act. We can basically call on hotels, not necessarily voluntarily, but we would reimburse them, of course, for the use, and we would clean it up afterwards. These would be safer spaces, hotel beds, hotel rooms, cruise boats that nobody's riding on right now, you know, and actually it would be good revenue for these places. It wouldn't be a bad thing. And that way we could expand our hospital spaces without having to build new spaces because they already exist. People are stepping up to the plate. In fact, FIU is stepping up to the plate. We're using our 3D printers to produce high quality masks and shields for the community. And in fact, I've been in touch with other schools that are wanting to join with FIU and produce these masks and shields because they have 3D printers they're willing to retool for this purpose. Remember, I love One Health, So I'm very, very interested in seeing the connections between human and animal medicine. And we've known for a long time that chloroquine, which was initially used in humans for malaria, not very much anymore, except in select places, because the parasite that causes malaria is mostly resistant to chloroquine. But we've known for a long time that chloroquine also has very interesting effects on certain viruses. Back when the SARS outbreak happened, soon after in 2004, 2005, so the SARS outbreak was over, but we were still worried that we might have something like SARS happen again, which in fact we have, okay? And so they started testing some of these drugs that were known to have effects. And chloroquine was one of those. And in the lab, it was very effective against SARS. And you have to remember that chloroquine has been used on billions of people, really, because it came out in the 1930s. It was the ideal drug against malaria until the 1960s, when we started to see resistance. And so we know that overall it's a safe drug. It's been given to pregnant women, it's been given to children, it's been given to adults with very few side effects. So it's a good drug, and I do agree with that. Moreover, during this outbreak, there was a decision to try a different drug that's very closely related, this hydroxychloroquine. That the idea came in part because in South Korea, they didn't have enough chloroquine. So they said, well, let's try hydroxychloroquine. So, and these are what we call observational studies. They're not double-blind, carefully done, let's prove that it actually is good or bad, but they're observational studies. And the observational studies in China and in Korea and now in Europe, and now also we're trying to do it in New York and in France and so forth, show that hydroxychloroquine seems to be even better than chloroquine. And we actually understand why. We know what it does inside cells that makes it harder for the virus to grow. And there's actually 3 different ways in which chloroquine and hydroxychloroquine affect viral growth. So those are very promising drugs. People are objecting to it, and some of us, in fact, I've been approached by colleagues of mine that are Chinese, French, Spanish, and also from Australia, that all want me to put my name on endorsing the use of chloroquine or hydroxychloroquine. And we've gone over the data very, very carefully, because there's been a lot of talk lately about maybe it's not a safe drug, and you know, there are side effects and we don't have all the data. And of course, that's somewhat true, but as my Spanish colleague has said, he's rather skeptical because it is a generic drug. Both are generic drugs, and therefore there's not going to be some pharmaceutical company that's going to make a fortune out of it. In fact, it's the kind of drug that the Defense Production Act can force pharmacies to make instead of drugs that make a lot of money for them on a daily basis, so that we have enough for everybody. That's another way in which the Defense Production Act could be extremely useful, because it's a non-patent level drug. I want to remind you and everybody that we were able to end the Ebola outbreak, the huge Ebola outbreak in West Africa, without an antiviral and without a vaccine. And those things take time. We want to get rid of this outbreak before we know we could make a vaccine. Even with the best, most optimistic and the most hopeful thing, the soonest we could have a vaccine is 1.5 years. And that's very, very optimistic. It's much more likely to be 3 to 5 years before we see a safe and effective vaccine, for a lot of reasons. So the truth is, we need to get rid of this outbreak using the same kind of public health measures that we used in Africa, and the same kind of public health measures that we see as being extremely effective right now in China, South Korea, and Singapore. Well, I think the first thing is they have to practice awareness. awareness of what they're doing and when they're doing whatever it is they do. So if you're going out about into the world because you need to go shopping or you need to go to an appointment for a physician or whatever it is, be aware that there's a risk that surfaces might be contaminated and that people around you may be asymptomatically shedding virus. So if you're aware of that and you realize the ways in which you can get infected, which include touching a contaminated surface and then putting your contaminated hands to one of your mucous membranes, then you interrupt that, right? So if you touch a contaminated surface and you need to touch your face, clean your hands. Then touch your face, right? Just so that's what I'm talking about with just basic awareness. And when you go out to the grocery stores and, you know, hopefully, and I do think most stores are being responsible about how they're stocking their supplies, it is still possible that there might be a contaminated box or something that you inadvertently touch that's contaminated with an ungloved hand, and that's perfectly fine as long as you remember, my hand might be contaminated, I must not touch my face until I've washed my hands. And if you're going to bring that contaminated item home that might be contaminated, then what I do is I have at my front door wipes that I actually wipe things down with before I bring them the rest of the way into the abode. And that just lowers my risk overall.